Hello, everyone. So, can everybody hear me? Okay. Well, I have been tasked with talking about this topic of neuropsychiatric aspects of Parkinson's disease. And some of you may have heard certain aspects of neuropsychiatric aspects by the other physicians before myself who have spoken about it really well. It kind of overlaps with the subject Dr. Eric Hart already spoke about, the other neuropsychological cognitive patterns of Parkinson's disease. So my goal today is going to be to give just an overview of what to expect and what psychosis is, and then how to go about managing it, treating it, of course, as well. So mine would be shorter, but I'm hoping that I'll be able to cover just the important parts, at least. So I will start. As you can see, the effects in these slides have been made keeping the topic in mind. So the biggest question is, so what is psychosis? Right? So psychosis basically refers to a collection, a constellation of symptoms that affects the mind and causes some contact or some loss of contact with reality. Parkinson's disease psychosis, which is our topic today, it refers to a spectrum of illusions, hallucinations, and delusions that occur throughout the disease course, but typically we expect them to happen later in the disease course of Parkinson's disease. Okay, next slide. Next slide. Oh. All right. So like I said, psychosis is common, but usually occurs later in the disease course. And the incidence of Parkinson's disease psychosis at baseline, basically at the time that somebody is diagnosed with Parkinson's, the first year and second year varies. So at baseline, it is about 3%. About the first year, it's about 5%. And then the third year, it is about 10%. Okay? And why does it, what causes Parkinson's disease psychosis? So it's usually from a combination of external and internal factors. So what do we mean by this? So briefly first touching about the internal factors. So internal factor would be, of course, the disease itself, how it acts, how it behaves, how it affects the body and mind. And then, as it progresses, because we all know it's a progressive disease. And then the other factor, of course, is unfortunately the medications themselves that are required to treat the disease. So it kind of becomes paradoxical, and we'll touch on how we could maybe do a step-by-step management on those. External, what are the external factors? The external factors become very important for us because we want to be able to take those out, minus those out before we start to think, okay, is this the disease itself or are these the medications that are doing this to our patients? So external factors, first and foremost, any infections, any external trauma, polypharmacy, the more the medications somebody is on, it places them at more risk for Parkinson's disease psychosis. Infections, chest infections, urinary tract infections kind of top the list, of course. And then any other existing psychiatric disturbances. Somebody already has a mood disorder like bipolar disorder, depression, anxiety. Those patients are more prone to developing Parkinson's disease psychosis. Okay? And all of these, of course, add to the complexity of the disease process and, of course, the consequent management of our patients. Next slide. Okay. So just briefly to go over risk factors, some other associated symptoms. So REM behavioral disorder, which of course it's been touched on before, Dr. Bulu mentioned it somewhat as well, that has been found to predict the development of hallucinations or delusions. And the severity of REM behavioral disorder symptoms has been associated with psychosis in patients with early Parkinson's disease without cognitive impairment. So what is REM behavioral disorder? It is usually it's manifested by acting out dreams, fighting, kicking out in sleep in a certain stage of sleep in patients in which normally people do not have much muscle tone, meaning that people do not usually move around much in that stage of sleep. But in Parkinson's, that does happen. So people with REM behavioral disorder are more at risk for developing psychosis. That has been, of course, it varies across literature, but it's been seen and it has been shown. it also places, so psychosis can, of course, place people at increased risk of dementia, nursing home placement, and consequent mortality too. Quality of life is also impaired, of course, as we know it, both overall and in subdomains of emotional well-being, daily living, and then cognition and bodily discomfort. Autonomic dysfunction, which basically means autonomic dysfunction or dysautonomia, that basically means impairment of our internal nervous system, that the nervous system that supplies input to our internal organs. And how it manifests usually is with patients coming in and saying that they're getting lightheaded, lower blood pressure. So those patients have also been found to be more prone to developing psychosis. So this was shown in a large trial, which was a study called ProPark that studied the cognitive profile of patients with Parkinson's disease. Okay. So big question, what does it look like? Well, we talked about psychosis. It's like this separation from reality, right? So what does it look like? Mostly patients come in with visual hallucinations. What are visual hallucinations? It's seeing things that are not there, simply placed. Usually when it starts out, these are minor phenomena. And we'll go over a little bit more like visual hallucinations, what kind can there be? Starting out initially, these could just be passage hallucinations, like just seeing something out of the corner of the eye. Presence hallucinations, the feeling that somebody is standing next to you. And then slowly these can turn into formed visual hallucinations. Typically, these are non-threatening. Earlier in the course of the disease, when no cognitive impairment has set in, patients usually retain an insight. They know, they have the ability to be aware that these are not real. And so that those hallucinations do not bother patients. And a lot of times if we don't ask, people do not even volunteer that information. So it's important to ask as well for us physicians. And why is it important? Because it guides the subsequent management. You know, if somebody has motor problems, then it will guide me to figure out what kind of medication to give them for their motor symptoms if they already have existing psychosis. So it is helpful for us as physicians. Now coming to the visual hallucinations, after that, typically after the visual hallucinations can come and set in some visual illusions. Visual illusions usually come initially, even before visual hallucinations set in, or along with them, concomitantly. What are illusions? Those are false perceptions. Like, for example, seeing like a branch of a tree, mistaking it, say, for a squirrel or something, or a leaf and mistaking it for a cat or something like that. And then people also see faces in clouds. So that could also happen. It's on a spectrum of normal to abnormal. Delusions that are false beliefs, those usually set in much later on, and they are usually accompanied by significant cognitive abnormalities. Usually people do have kind of the initial stages of dementia once the delusion set in, unless they have had a delusional disorder to begin with, like I said, pre-existing psychiatric problems. So I mentioned this before. Initially, there is intact awareness, and then patients are aware and easily redirectable. So, okay, so I really liked this picture. So this is from the Nature, and it is from an article published by a highly reputable group in Britain. What I liked about is that it really pretty much says it all, what I was describing in the previous slide. So this bar to your left, so to your left talks about, basically mentions the cognitive profile of patients, and the bar to the right is basically mentioning the stages of Parkinson's disease. Now the stages of Parkinson's disease, as one should be aware, are overlap from patient to patient, and they kind of have a very big overlap, and we mostly use them for research and study purposes, but basically for this our Hone and Yar staging. So if you look there, up there on the left side, for the left bar, the darker pink, and it goes from dark pink all the way down to light pink. So starting out when the patient is just in stage 1, in which they just have mild symptoms, usually limited to one side of the body. The kind of psychosis they would have, minor psychosis, would be some minor illusions. For example, over there, they are mistaking that the leaf for a cat, and then some passage hallucination, something just walking past them. The presence of a person next to them. They can also have some double vision, which could also be related to some of that decrease in depth of visual perception. And there's also been shown to be some disturbance in the visual pathway as well in patients with Parkinson's. So that can happen later on, once people are kind of in that stage 2 portion. People have formed hallucinations with retained insight. Interestingly, usually these are hallucinations of familiar people, relatives, little people. Like the ones classically described are the Lilliput hallucinations of the classic Gulliver's Travels, if you are aware of that. So hallucinations with insight. So at that point, you're able to tell your loved one, these are not real. And this is, and they're redirectable, they understand, and just go about their way. Later on, it's usually in the stages 3 and 4 that we start noticing these hallucinations without insight, and that is when it becomes problematic. It is hard to redirect somebody, and in certain situations, it is maybe not, it's better to not pick a battle over what's right and what's wrong at that point. And of course, delusions set in at that stage 4, between the 3 and 4 portion. Again, these can all overlap as well. In addition to visual hallucinations, patients can also have auditory, meaning hearing things that aren't there, sounds, and olfactory, meaning smelling, abnormal smells as well. Those would be hallucinations separate from the decrease in sense of smell, and tactile as well, feeling. These are unusual, but certainly not something that cannot happen. Right? So I'll just switch gears here, talk about management strategies, because my goal here is also to help caregivers and everybody understand how to maybe go about, okay, now that my loved one is having these hallucinations or the psychosis, how should I handle this, right? And so now that we know those can happen, then first of all, if somebody is kind of still within reason, you can redirect them, you can explain to them, and if things are good, they can, it can be very understandable. They can be very understandable of what's going on. Then you also want to, if things were fine, never had these psychosis symptoms, and now they just started out, then the first thing, rule of thumb, would be to make sure nothing else is going on. There were no infections, they're not dehydrated, it's not the summer, they're walking around outside and they're dehydrated now. Again, they're dehydrated, they already have some hypotension, like decrease in blood pressure, now they're lightheaded, now they're also having psychosis. Electrolyte abnormalities, something that you would just kind of find out from a blood draw. Any sleep cycle abnormality, are they sleeping okay? So Parkinson's, as you all would now, at least towards the end of this thing, this whole sitting that we've had, be aware it's all multifactorial. Every small thing makes a big difference. So sleep cycle, you want to address the sleep if somebody's not sleeping well. And then to maintain the living environment as close to normal as possible is very important. Now, that's not always possible, especially in those later stages in which somebody is now having some major neurocognitive decline. Then a lot of patients do end up having to go into placement for their own safety as well, of course. So, but as close to possible as to normal as possible. And then we want to go ahead and treat these specific variables, right? So if there's a sleep problem, we treat that. If there's excessive anxiety, we also want to treat that. All the contributing factors. Like I said, every small little variable can make a big difference. A very big one there, that's one of the first things I do. I look at medications. Is there something that could be making things worse? Is there something new that was started by myself or by some other physician? Yeah. And so that is very important. And then comes the portion, going back to what I mentioned before, the Parkinson's medications that can themselves worsen psychosis. So at some point, one has to strike a balance between helping those motor problems, those slowness, the stiffness, and the psychosis. And once we've looked into all other variables, then one can look into, okay, is this one of the Parkinson's medicine making someone worse, or can I reduce that? So my first go-to is actually reduce the anticholinergics first. It doesn't say here. That's one of the first ones I go for. And those are usually medications that have been given for tremor. Trihexyphenidyl, those medications. Benadryl. I've had some patients taking Benadryl just for sleep at night, and so I work on those as well. But trihexyphenidyl is one of the Parkinson's medicines that can be given for tremor. Artane is the usual name. So usually I do not even prescribe it much to a lot of my patients because of some of the side effects, but I would stop that. Dopamine agonists like pramipexole, ropinirole we can start reducing those. And then amantadine, which works great for some symptoms, most symptoms actually of Parkinson's, works great for tremor, good for motor control, and great for the wiggles. So have a lot of patients on amantadine, but that's also one of those medicines I start to cut back on, unfortunately. And then lastly, if able, we reduce the carbidopa, levodopa, if it comes to that. Like I said, striking the balance is the main thing. And then you can then start to talk about adding medication specifically for psychosis, or at about the same time that you're thinking of reducing the Parkinson's medicine, that is the point that, okay, I still need the Parkinson's medicines there to help the motor symptoms. Now I'm going to go ahead and add something for the psychosis. So that's when, and we'll mention that in the next slide, the medications. So the specific treatment, specifically the medication number 3, pimavanserin or Nuplazid, that has been FDA approved specifically for Parkinson's disease psychosis. But that doesn't mean that the others aren't out there. So my first go-to is quetiapine or Seroquel. And I think a lot of our movement physicians go for that, just because it is more widely available. It works well. It works more. I have seen more immediate benefit with that. And we only need a low dose. And so it works well for my patients. It can make people quite sleepy. So I usually cut that in half and just start out really low and slow. Clozapine is the more favored medication, but because of some tediousness in having to monitor blood counts, it is not used that often. At least I do not use it very much, but it's a great medication too. And then lastly, I want to just touch on this donepezil. Donepezil is a medication that is indicated for the early stages of Alzheimer's. It is also given to Parkinson's patients with cognitive decline, the cognitive, not just the psychosis, but it has specifically been also in some studies shown, and I have also had first-hand experience, help people with their psychosis too. So it can benefit someone with some dementia syndrome or cognitive profile, decrease that cognitive profile and psychosis. Then donepezil for me has been a good alternative to the other ones. And then response to treatment varies amongst individuals, amongst people, and individual adaptation, tailoring the medications if that may be needed. None of the currently available treatments is effective in every patient, and of course new treatment research is needed. There is always that need out there. I looked up, these are several clinical trials that are currently active, so you could jot those down. And I think that should be it, but let me see. So that's just some references there. And this is the lady who helped me with the effects. So. Thank you. Thank you, everyone.